Perfect. Welcome. My name is Brackon Lundy. I'm a physical therapist with the Physical Therapy and Sports Medicine Department here at North Kansas City Hospital. Today, we're going to be talking about returning to sports and some of the things that go along with that. And we're going to focus on the lower extremity. Got the typo there, wonderful. And that's a great kickoff. So, before we start, again, my name is Brackon. I've got certifications in orthopedic manual therapy and strength and conditioning specialties. A little bit about me. My main hobby is spending time with my family, and they allow me to do this and kind of bring a lot of happiness to my life. And besides that, I really love mountain biking, getting out on trails, off the roads, and of course, you got to pick up heavy stuff, stay strong, and be physically capable. So a little bit of background about myself. One disclaimer that we're going to start with this talk is I am a physical therapist, but I'm not your physical therapist. If you have rehab that you're going through and anything, you always want to talk to the people that are familiar with you. And so we're going to go through some general recommendations, and I'm going to tell you to always consult your medical team and the therapy team that you're working with. If you don't have one, we'd happy to work with you. But there always is specific instructions that may be more appropriate for you at that time. Our goals for this talk are going to be understanding some common injuries and some healing times and recommendations. We want to introduce some physical therapy concepts as far as recovery and treatment goes. We're going to talk about some performance-based return to sports and return to activity measures that we like to use and the research supports highly. And then we're going to discuss some different concepts as far as returning back to regular activities in sports. As far as we know, we love our runners and, people going back just to the gym, people specifically going back to boot camps or CrossFit type activities, where that may be a little higher intensity, and we need to make sure that we're prepared for that. And especially the people going to competitive sporting, we want to make sure that we're setting everybody up for success. So that's our goals for the talk today. Some common lower extremity injuries we're going to kind of think about when we're going through this. We have general just pains. Maybe I've kind of sprained or strained a muscle or kind of tweaked my ankle or done something that just throws me off and I can't quite get through my normal day-to-day activities. We can have some more specific things like I've had hip surgery or maybe a labrum repair, an osteotomy, some of those words you may be hearing from the physicians. Especially we see a lot of ACL or ligament repairs in the knee. Those are very common. We can have meniscectomies or meniscus repairs in the knee, and then kind of lower in the ankle, just generally, maybe an Achilles injury, Achilles reconstruction, or some other ligament injuries as well. Kind of like Aaron Rodgers over here. Unfortunately, he had one of those early in the season. So when we're looking at injuries and how we want to initially approach those, is we want to first triage, what's going on. Is this something that is severe enough that maybe I need to go to an ER or an orthopedic ER or urgent care? And maybe it'll wait a little bit and I can see the medical doctor and get into my primary care physician or somebody. Or can I go to directly physical therapy? And in Missouri now, physical therapy does have direct access. So you're more than welcome just to call your therapist or the physical therapy department and say, hey, can I get in for an evaluation? What the research is showing, and we've had a couple updates through the years, we used to talk about RICE, rest and ice and compression and elevation. Now we kind of talk about this acronym, this peace and love. At first we want to protect our injury. We want to elevate it. We want to control the swelling. We want to keep it from getting big and limiting us. Sometimes those anti-inflammatories can really reduce our healing mechanisms. So if we don't need those for pain control, and the physicians aren't really telling us that we need those and we can go without that, we may look to avoid some of those anti-inflammatories, ibuprofens and stuff like that. If we're having some swelling, maybe we have some light compression would be beneficial, just to keep that out of there. If it swells, we know it's going to do some things as far as limiting our ability to use the muscles, increasing pain and pressure. So, we want to keep that from happening. And then we want to educate and understand what's going on. Maybe I have hurt something and I need to get further testing or further, imaging involved, or maybe I've just kind of sprained or done a little bit less or a lighter injury, and I can just rehab this with our therapists. And so we'll go and we'll talk about that LOVE acronym a little bit later. But when we're past that initial inflammatory phase, the first 2 or 3 days, we want to start moving and loading our tissue and want to be optimistic about our prognosis and our overall outcomes. We want to help get blood supply to those tissues so they have the nutrients to repair and to get better. And we want to start getting into some exercise when it's appropriate. If we go too quickly with that, we can always set ourselves back and irritate some things, but at a certain point, we need to get back to doing those things, especially if we want to get back to running or, CrossFit or sports. We have to exercise eventually. So in that last bullet point, so we want to talk about ice. A lot of times, ice has been pushed and pushed, and what we know is it really can constrict the blood vessels and again slow down our natural healing processes. So ice is really, really good for helping control pain in that acute, couple days afterwards. But eventually, we need to get away from that. And some of the things as well is if our pain is controlled well, then maybe we move away from ice, and we don't really need that. We can use some other things like that compression and elevation and other modalities to control those symptoms at that time. So ice isn't always the answer, but it can help acutely with those pains if we're trying to stay away from medication. We want to say we always are working with in step with our medical physicians. They're going to help us again with that pain management. If we need to consider surgery or further testing, they're going to be on our side. So whether you're starting with therapy or starting with the physician, we want to be in step with our medical team. And from the therapy side, we want to have some considerations that we look at, and that is, hey, what aggravates this? What makes it feel better? What are the pains and symptoms that we're having? Is it sharp or dull, or are we getting some weird symptoms like burning or tingling, numbness? We want to know those things so that we can make sure we're doing the right stuff for you and using those referrals like our physicians to help. Some of the different activity limitations, if we're coming off of an injury, depending on how bad it is, we may say, hey, let's go a little bit easier on some things. And so that we don't aggravate it as we're building back up to, say running or CrossFit or something. Especially if we're coming off surgery, we're going to have some limitations because we got to let that surgical repair heal. And that kind of goes into our precautions and our protocols with the surgery, is there is going to be a little bit more of a stepwise return to activity and healing time frame that we're going to want to look at. So we're going to look at, with our recovery, 2 different tracks to kind of consider. Our surgical track, we've had some repairs. We're going to be really particular about healing timeframes and specific progressions so we don't overload those tissues that are healing, so we have the best outcomes we can get. And if you come to us with just an injury and it's not surgical, we're going to probably use some more symptoms and tissue responses to guide our return. We're going to help move some fluids, and we're going to help build back up. A lot of times we can progress through those same type of time frames and progressions quicker than a surgical person could. In general, we have specific time frames that we think about with different muscle injuries or different injuries in general. You can see, hey, if I've got a tendinopathy or a tendonitis or something, I may be looking at days to weeks. Or if I'm having a ligament strain or a ligament injury, I may be looking weeks to months. And if I'm having that ACL graft or some type of ligament graft, that Achilles tendon repair or something, I'm probably looking months or longer for full healing and full return to sport. So we want to set out with the right time frames to begin with. And so that's very important. So when we're talking about surgical recovery, we have some different phases that we go through. And our initial phase when you come to therapy after that surgery is we're going to protect those healing tissues. We want to assist with, what we can as far as what we can movement wise, different things that we should avoid, really learning and understanding what's going on and why and what the time frames are for our return. So that protection phase, we're going to be doing a little bit of stuff and we're going to be planning a lot of things. And then pretty quickly, hopefully we get into that intermediate phase where we can progress some guided activity. Maybe we're doing some more active motion, or we're able to get into some strengthening that isn't directly on to the repairing tissues, or maybe some of the stuff around it. And then later on, we're going to get, towards that strengthening or our sport, return to sports phases where, we're going to be pushing the limit. We're going to get back to the things that look like sport and look like, gym activities. We want to build the strength. We want to build our ability to run and jump and all of the things that we need to be able to do to get back to what our regular activity is. So, we have that on the right. We have some agility that can start. This chart is kind of looking at what an ACL would look like. And really, if you look way down the line, we're doing maybe practicing 6+ months, and we're not competing until, this is even probably accelerated, but probably 9+ months for full competition. So maybe some, practice and drills and really getting into sport-like activity without really going out and playing that sport quite yet. So post-operative phase 1, we went through this a little bit. We're going to reduce pain and inflammation. We're going to protect those repaired tissues. We're going to get you moving. We're going to get within our limits of what we can do without putting bad strain on the healing tissues. And then we're going to advance into that phase 2, and that initial loading phase, we're going to get you moving. We're going to get those tissues that are healed moving a little bit. We're going to restore some range of motion. If I'm thinking about my ACL rehab, we want to start bending the knee, getting into some light stretching as it's appropriate. But we're going to continue protecting some repaired tissue. So we're going to not overload that graft. We're going to specifically tailor some programming things to your repair. And then phase 3, usually around 12 weeks, we get into some real fun stuff, full strengthening, full stability, conditioning work. Later on, we're going to talk about our return to activity and return to sports criteria that we use. And we start thinking about this around phase 3. And what do we need to do to be able to run and get into some of those fun things again. And then once we're there, phase 4, maybe 16 weeks or further out, we're going to look at dynamic stuff, hopping, plyometrics, getting some power back and doing some really fun sport-like stuff, getting into some cutting and change of direction activities. So we're going to go and jump over to that non-operative kind of post-injury side, our other tract, when we go back to our recovery. This is where that LOVE acronym comes in. We're going to load that tissue. We're going to be optimistic about what we're doing, vascularize, exercise. We're going to go through some similar phases as a surgical, but we're really not going to be as specific with our limitations and progressions. It's going to be more as your symptoms are controlled and as our goals are met. So how do we know how to progress when we're going through that? I'm not a big fan of saying, at 8 weeks we can do this, or at 12 weeks we can do this. Medically from the side, we need those healing times and those tissues to be ready. But from the therapy side, I need to see some other things. So if our tissues are tolerating activity and our pain and soreness are controlled, it doesn't affect how we're moving. I'm not walking different or having to, change how I'm moving. Then it gives me some better information that really we're doing what we want to do. If we're exercising, we can have some soreness. It's not abnormal to go to the gym and have some soreness afterwards. But I don't want that to be longer than a day or two. If that lasts longer, we're probably overloading those tissues. If that pain level goes up, above those lower pain scores with a 0 to 10 score, we maybe need to back off or give it some more time to catch up. And then we're going to use our objective testing to tell us really when we can do certain activities. And so our objective testing, I split into two different things. One, we have kind of returned to different regular activities, running, just day-to-day stuff. And then we have a second set of tests that are hopping and agility based, that are return to sport tests. And we use that for those higher level athletics, our competitive athletes, maybe those CrossFitters or some people who are really looking to get back into some high levels of activity. Our return to activity, our weekend warriors, just running, general gym people. If you want to go in and lift and get strong, we can get back to that a little bit earlier than maybe our competitive athletes and our CrossFitters who are doing, power lifts or Olympic lifts or something like that. Our first level of activity testing, and this goes for either tracked, post-surgical or non-operative, we want to look at our outcome surveys. Is this limiting my day-to-day activity? Is it limiting me getting up and just walking around, going to work, doing my normal things? If I'm looking at post-op stuff, I'm going to look at some girth testing. If I'm looking at an ACL recovery, I'm going to be measuring your thigh circumference in a couple different areas. If you have more swelling around the knee, it may be swollen. We may need to step back and think about controlling some of that swelling. If it's up higher into the thigh, maybe we need to look at building some muscle size. If I've got one leg that's considerably more impaired or smaller than the other thigh, it's kind of like running on a flat tire. I'm not going to be able to be as strong in that muscle. Our motion needs to also be even side to side. If I'm not able to move the same through my hurt leg or my post-op leg, then it's going to put some strain on that tissue that we don't really want. And then I like to test strength. Is my strength within, our group likes to use 85 or 90%, and that's what the research really shows is a good number. We should be pretty close to as strong on both sides as we want to be. And then we have some power testing, how many heel taps or how many repetitions can we go through in 30 seconds or a set amount of time. So we're really pushing, quick and trying to get a lot of repetitions up and down. And maybe some Y balance, so some balance and proprioception and control. Am I equal side to side, or am I a little bit unstable on my hurt side, and showing that maybe I'm not quite ready to get back to all of those running and upper level activities yet. So that'll give us some direction as far as therapy goes of where we need to tailor the program to you. Somebody may come in and have a strength deficit, but not a balance deficit. Or somebody may be really strong and balanced, but man, they can't really put much power through their hurt side. It's too painful, or they just don't have that next gear. They can't get up and go. So that'll really drive where we can be specific with our interventions in therapy. And then on that second level, we're getting back into getting into those upper level activities and returning to sport and going back to practice, those type of things. Well, we want to be able to withstand that. So we're going to look at one side versus the other hop tests. Whether it's a vertical or a long jump, we're going to see one leg versus the other. Can I really push off and get some dynamic hop with that one leg? Repetitive hop, triple, 1, 2, 3 in a row. Can I bound 1 foot over and over again and be able to withstand that force one side versus the other. Crossover hop is kind of like the triple hop, except we go a little bit inside and outside over a line. So we add a little bit of third dimension side to side. And then 6 meter timed hop, that's a race. We throw out 6 meters and we see how far you can get or how fast you can get through that one side versus the other. So we use speed, we push power in this, and we compare again one side versus the other and see, hey, are we within that 85 to 90% threshold? If not, maybe we need to again push some power or push some other specific traits in our interventions. And then finally, our agility tests. That pro shuttle where you start in the middle of one side to the other and then back through, and then the T test where you go and you run that T back pedal back. And those are some standard measures that, a lot of teams will run in practice or agility, or, you may see some stuff like that in even the NFL combine or something. So there's some really good measures we can compare to see, hey, are we back to within some standard measurements compared to, regular athletes. We do this, and we are very specific about this, especially with our post-surgical patients for several reasons. When we release you, we want you to be confident and able to return. And so when we do that, we say, hey, the research shows that if we're meeting these criteria, especially for an injured, for a post-op ACL, we have single-digit risk for re-injuring that ACL. There's some things we can't really get that to zero because if somebody falls into us or something, we can't control that sometimes. But when we're getting back, we want you to be ready to get back and ready to kick some butt. So for those people who don't pass those tests, we have a really high re-injury rate. And so when we see you, we want to say, hey, I'm confident that you can get back, and you should be too, because this is what the research and this is what our professional opinion and experience tells us. And I mentioned that 9-month date with the ACL rehab earlier. We know that our body is still going through remodeling and change. And this goes a lot with those ligament reconstructions, where if you go back too early, we're just not physically ready to get back to that. So every month we delay that, work on these activities and strengthening and power, our risk of re-injury goes down. And this is different from everybody. We see pro athletes trying to get back, 9 or less months. And that's great. It's a little bit different, those pro athletes who their entire job is to get back and go and have all day to do that. And then us, like myself, who are the weekend warriors, and we've got to work and we can't focus on rehab 100% of the day. It does benefit us to delay that a little bit and to get ready and to promote some of those power and strength capabilities before we do that. So we're going to shift and go back to, we have some returning to running progressions. When we reach that first one, if we have the strength and the power that we can go back and say that we're ready to run, usually we get into a couple phases, our first phase, and we should be doing this, probably early, but we're going to do some treadmill walking or just having you walk on your own. Walking is beneficial, blood flow, healing, as long as that isn't messing with any symptoms that I'm having, we can walk early. So as long as our gait characteristics or how we walk looks good, I'm all for it. When we're able to, if we're talking ACL rehab, maybe around that 12-week mark or something, maybe we'll be able to start some plyometrics. We know when we're running, we have studies that tell us how many foot contacts per mile that we have, and it's a lot. We're jumping 1 foot to the other. And so we want to build up first with 2 foot and then with 1 foot contacts. And we want to be making sure as we're building up and loading those tissues that we want to be mostly pain-free. And again, we talked earlier, if we have a little bit of soreness after the fact, that's controlled. And we're okay with that, as long as it goes away, within a reasonable amount of time, a day or so. If we can do that, then we get into quickly our walk jog progression where we do a couple repeated bouts where we build up, maybe a 4-minute walk, 1-minute jog, and then we can start with a couple of rounds to that up to, half an hour. And so we build slowly 3 minutes of jog, 2 minutes of run or walk and then run, and then 2 minutes of walk, 3 minutes. You see how it goes up to where we're just jogging, and we can jog up to, 15 to 30 minutes. If you're doing that, then we're ready to rock. And then if you are a competitive runner or if you're training for something specific, like our 5Ks or halves or marathons, maybe we get into more of those specific running progressions about working on speed and splits and things. But most people will be able to take that third phase and get back into recreational jogging just fine. When we're running, we're going to manage that pain and soreness. Like we said, if it's under a day or so, then we're mostly happy. But if we have an ache if we have an ache that goes away when we're warming up, usually we're in a good place. If that ache worsens when we're warming up or we're starting to do more stuff, or if that pain gets up above that, three or so out of 10 pain scale, more than that tolerable amount, maybe kind of stop and take a little bit of some rest and recovery time. If we're not able to move or walk or run normally, we're kind of limping around or changing our pattern. We're gonna really make some other things unhappy too. So we don't want to kind of kick ourselves in the when we're trying to get better and set ourselves back. So if we have those pains that aren't going away, aren't tolerable, and are lasting too long, maybe we need to take a step back and not do as much, focus on recovery, give us some indications that our tissue maybe isn't ready to do all of that. For our people who are going to the gym, our strengthening things should really look like gym activity. When we're going in, we're looking at, we're going to be doing squats and probably lunges and like a single leg step up, some different things. So what I like are some really getting back into basic starting strength programs. There's a bunch of different stuff here, but when we're really looking at building some things, maybe we can get into a 3x5 or, a 5-3-1 would probably be a little bit more aggressive if we're pushing, a 1 rep kind of working max, but maybe going through some 3x8s, something like that, to really build up some of our starting strength programs. If we notice that our quad or our thigh is smaller on one side, maybe we need to be doing some hypertrophy specific repetitions. Those general recommendation bullet point there, 2 to 5 sets, 8 to 12 reps. If I've got one thigh that's smaller than the other, I may be doing some really specific things to beef that up and really to get some load into that to increase that muscle size. And generally, I like to do those basic patterns: squat, hinge, or deadlift. A loaded step up. Vertical push pull with our arms. So that'd be our bench or our rows. Doing vertical would be our overhead press or our pull ups or lat pull downs, or the horizontal push pull, which would be our bench or kind of horizontal rows. Those are going to set us up for really good athletic and general achievements. And from there, you can always get into more specialized programs. But when we're getting into these things or after injury or after surgery, it's a really good place to start getting some activity and some time to build that tissue resilience back up. If you want to go and do Olympic lifts, some of those CrossFitters and things may want to do these. We have a lot of good technique things that we can look at, starting with a cane, PVC pipe or a broomstick. I see often looking at those techniques, making sure that those speed movements are tolerated well. And then from there, we can do some empty barbell and loading. From that, we know that those low catch positions, when we're catching like a clean or a snatch, are really a lot of force through our knees and our hips. So again, this is later on. We probably want to be able to pass some of those hopping tests and say that we're ready to do this level of higher intensity, quicker activities. And then, like I said, those low catch positions are a little bit harder on us. So we can start with some power version or catch those up higher in that position. So we're not in a full depth squat when we um, receive that weight. So some different things to think about getting back into those Olympic movements. Our CrossFit people, we love to push ourselves. So when we want to be comfortable with our power movements and our strength movements, when we're talking to our coaches, we want them to know what our situation is coming back from injury, so they can help us scale those workouts. The first time I go back, and even the first little bit of time I'm working with my coach, I want to scale those movements so I'm not overloading things. I don't need to be doing 5 rounds of 20 squat thrusts or something if I'm coming off of an ACL replacement or a knee surgery. So I got to scale down that workload so that I can tolerate and build that back up. And just that lower bullet point, we're going to consider using our return to sport hop and agility testing before we really go into maybe a prescribed workout, or when we're advancing towards that prescribed workout in CrossFit. So we want to make sure that our physical performance is ready to go full bore. And then we have sprinting. If I'm going to get into competitive sport, I'm going to have to sprint. And there's usually some different stages with that. I should already be running. I should be doing plyometrics. Our stage one is building capacity. So these are things that I want you to talk to your therapy team about when you are specifically ready for this type of stuff. Obviously I'm going to tell you we're not going to go out the first day and do max effort sprints. It's a good way to re-injure yourself. So we want to build that capacity. And I tell you what, when you haven't run for a while and you're trying to sprint even 50% speed, you get pretty gassed quick. And then you build into that stage two. We're going to working on that technique. Is my arm swing and my leg kick and everything, leg drive, going to be what I want it to progress? So we're moving fast at 75% with that stage two. And then stage three, maybe we're doing some sport specific stuff. If I have some soccer people or other things, maybe we aren't doing straight line sprinting, but we can do some curved stuff, and we're going to be doing agility work as well. So there's some other specific things that we can look at, but we need to have some ways to get back into sprinting and regular activity, as well as just our day-to-day stuff. So each of these are important for different people. So in summary, we want to listen to our body. If our body in these injury states telling us, hey, this is a little bit much, I'm not recovering well, we have those pains or aches that are hanging on, longer than a day or so, aren't getting better when I'm trying to loosen up or warm up, let's not rush it. We've got time. I know when we're recovering, we want to go and we want to be able to do everything yesterday. But if we go too fast, we're going to really just put the brakes on our own recovery and really stretch out the time to get to where we want to go. And so what we want to do is build up that miles and load. We want to build that activity tolerance, make sure that we can do and withstand what we're asking our body to do. If I'm going to go out and run 10 miles, I got to build up to that. There's no way that I can step outside today and go run 10 miles without kind of injuring or irritating something. So, and we want to use our medical team as a resource, our physical therapists, our physicians, our orthopedic specialists. We're there to help you guys. So, do let us know as far as, what we can do, when it's appropriate. And we're all here to really help. And that's what we want to do is give you guys the best information and help kind of tweak what we're doing to get you there a little quicker, a little bit better. And when we're getting back to that stuff, be a little bit less likely to come back and see us. So when these are general recommendations, we know that individually we're going to work with you on specific things like we've talked about, but hopefully this gives us a really good kind of overview of what we're thinking about as far as time frames, about specific things that I want to be able to do, you should be able to look yourself in the mirror and say, hey, am I really as strong on this side, or am I really balanced on my injury side versus my non-injury side? Or like when I go to push and try to drive with power, am I a little sluggish? So we want to be here to give you those keys to getting back to doing what you want to do. All right, and that kind of brings us up to the end. Our North Kansas City Physical Therapy and Sports Medicine has 3 clinics. We'd be happy to work with you and work with our local area physicians to help you out. But right now we'll take questions if anybody has any. And Jackie, I'll kind of give it back to you.